Welcome to the EHE 360 Connect educational webinar, Histotripsy as a treatment option for EHE. My name is Maggie Cameron, and I'm the Director of Development and Communications here at the Foundation. And I'm also a patient, so I'm looking forward to this as much as many of you are. Okay, so with that, I have the distinct pleasure of introducing the EHE Foundation's Executive Director and Director of Research, Denise Robinson.
Hi, everyone. Thanks for the intro, Maggie, and thank you for making time to join this session of EHE 360 Connect. We are really pleased to bring this educational session to you today on the topic of histotripsy, a newer innovative treatment for liver tumors. It has raised a lot of questions among the EHE community, so we're all eager to hear these experts' information today. And to provide a comprehensive overview of this intervention, we really wanted to bring in a multidisciplinary team, including medical oncology, radiology, and surgical oncology. So to get a better understanding, we have asked for specialists from two excellent institutions in Boston. So we have Dr. Michael Wagner, who some of you may already know. He is a medical oncologist specializing in the treatment of sarcoma at Dana-Farber Cancer Institute in Boston. And then we have Dr. Paul Shyn, who practices interventional radiology at Brigham and Women's Hospital, and Dr. Jiping Wang, who is a surgical oncologist at Dana-Farber. So these three gentlemen are going to talk with us and give us their expert perspectives on this intervention. I think that we'll hear that there's little known about this for EHE, but again, we encourage you to take this information today, write your questions down, and take those back to your care team as you need to. So I'm going to welcome, I think Dr. Wagner is going to be on first, so help me welcome our panelists, and we look forward to hearing from you, and we'll come back to Q&A afterwards.
All right, thank you very much. So I hope everyone can see my screen and my slides. But just as a full disclosure, so I am going to give a very brief just introduction to kind of set the stage for Dr. Shyn and Dr. Wang, who are going to talk in much more depth about histotripsy. But I think to understand sort of when would we consider histotripsy, it's important to really understand just kind of the basics of EHE, and then also what are some of the other options as well. So of course, I'm a medical oncologist, so I'll focus on the medical side of things. These are some of my disclosures. So of course, you all know this, but EHE is a very rare tumor where there are only about 100 new diagnoses per year in the whole country, in the US. And that has stayed stable fairly pretty much over the past 20 years, where the incidence is about 1 per couple million people. So it's an incredibly rare tumor. And that means that all of the data, whether it's for systemic therapy or surgical interventions, is really based on small case series and a few small studies. So for anything that we use for EHE, we just don't have the really large randomized clinical trials like some other cancers do to help guide treatment, which makes treatment decisions very personal and very case specific, and always a conversation between the patient and the treating team. As you know, EHE can come up anywhere across the body. So it's a cancer or growth of the blood vessels. About a third come up in the skin or soft tissues. And importantly for this session, about a quarter of EHEs will come up in the liver. Another 20 or so percent come up in the lungs and 13% in the bones. And then, of course, there are other sites as well. Molecularly, EHE is characterized by a few pathogenic or classical fusions or changes that happen in the chromosomes of the cancer cells. The most common one is the WWTR1 CAMTA1 gene fusion, which happens in something about 80+% of patients with EHE. And then the rest have a YAP1 TFE3 fusion. Both of these fusions involve an important cellular pathway called the Hippo pathway. The fusion is important because there is a prognostic difference between the different fusions, where patients whose tumors have a YAP1 TFE3 fusion actually, on average, tend to have a slower uh, course of disease and, on average, tend to live longer. But knowing all of this can be very important for helping to guide future treatment options. So now that we know that these fusions are present in a number of patients with EHE, or virtually everyone with EHE, we can study these fusions and understand what are some of the other pathways that are activated, and then we can become a little bit smarter about choosing systemic treatments and designing clinical trials. There's at least some data that's known. But I think one thing that's important to note is that EHE is a very difficult tumor to predict how any one individual patient is going to do, because even with disease that has spread, it can behave very indolently and grow either very slowly or sometimes even not really grow at all over time. So one of the first, I put in quotes, interventions is actually to monitor very closely. And that's because some patients can actually live for many years, even with metastatic disease, without any active treatment or intervention. When do we actually consider starting something systemic? So if we document that the tumor is indeed growing over time, if there are a lot of symptoms, so as most of you know, EHE can often cause a wide variety of symptoms, notably pain, sometimes fever and weight loss and fatigue. And sometimes these symptoms are kind of vague and systemic, even though the tumor might be focal or limited to one part of the body. So if someone is having any of these symptoms and there's no clear other cause, then that in itself can actually be an indication for some sort of treatment. And then the presence of effusions or fluid, most commonly around the lungs or in the abdomen, also suggests that the disease is behaving much more aggressively and would be a reason that we would start some sort of treatment. We have some data for various systemic medicines. There are a few that are considered standard and approved just in general for sarcoma, and that we extrapolate and then use for EHE. Because it's a vascular tumor, one of the other types of cancers or other sarcomas that will sometimes use to guide our choice of treatment therapies for patients with EHE is the way that we would treat angiosarcoma or a different type of aggressive vascular cancer. But even that's also very rare, and data is sparse, really, for guiding treatment for either of these diseases. One of the first things that we'll use sometimes is chemotherapy. And the drugs that we'll most commonly use for EHE are a class of drugs called anthracyclines, so things like doxorubicin or Doxil are the most common anthracyclines, and they're also some of the oldest cancer drugs that have been around for many decades. From at least one series looking at patients with EHE specifically, it took a little bit less than 6 months for patients from start to finish to have documented tumor growth. And then similarly for taxanes, which is just a different class of chemotherapies, so paclitaxel and docetaxel are two examples of taxanes. The median progression-free survival, or the median or average amount of time that it took to show from one scan to the next that patients' tumors had significantly grown, requiring a change in treatment, was about 4 months. So definitely a lot of room for improvement. And then the next drug that I want to mention, just because it's an approved drug for soft tissue sarcomas, is pazopanib. So that's a drug that targets one of the important pathways in blood vessel development. So at least intuitively, it kind of makes sense that it might work for a vascular tumor like EHE. But it turns out it's not terribly effective. It might be effective for certain patients, and there's actually some suggestion that it might be more effective even for patients with liver disease primarily, which is especially relevant when we're thinking about histotripsy, because that's an intervention that we think about most, at least in the liver. But this is one of the other options. The average amount of time that it took for tumors to grow, again, in this fairly small series, was 2.9 months on pazopanib, where just a quarter of the patients even had stable disease as what we would call the best response, meaning the tumor just stayed the same on the drug. There are a number of non-chemotherapy drugs that are used in some cases actually fairly widely, especially sirolimus has, I think, had fairly rapid adoption, I would say, over the past few years for treatment of EHE, where, as most of you know, there's now a consensus guideline that really prioritizes sirolimus as a treatment, and it's used at a lot of sarcoma centers. The average amount of time on sirolimus, at least from the largest study that's been published so far, which was actually from the Italian group, was a little over a year. So that's better than any of the drugs previously or on the last slide, but still certainly room for improvement. About 1 in 10 patients on sirolimus has a response, meaning significant tumor reduction. There was a fairly large study, or at least large for EHE, looking at trametinib, which is a MEK inhibitor. This was run through the cooperative group called SARC, where, again, the results seemed a bit better than what we would see with sort of the typical chemotherapy. But still, the average amount of time before growth was less than a year, and a small number of people actually had significant tumor reduction. However, on this study, almost all of the patients noted at least some level of tumor reduction, but that it didn't quite meet the threshold that was required for the study to be called a response. And then also importantly, this study showed that with treatment, there was improved sort of pain outcomes. So patients' pain and symptoms improved, even though the tumors were still present on treatment. Another immune therapy that has actually been studied in EHE is interferon alpha. So there are a lot of different types of immune therapies. The only one that I'm going to mention right now is just interferon, where there have been several small case series and at least one larger study looking at interferon alpha, and the response rate was actually higher than any of these other drugs. I honestly I'm not 100% sure how to interpret that because it's not a drug that's widely used, at least in the US. The version of interferon alpha that was used in the clinical trial is not even available anymore. So there is a different formulation of it that some people might use, but I think we really need more data to really make an assessment for whether interferon alpha should be used more broadly or not. From what has been published, the average amount of time before patients tend to have their tumors grow is about 9 months on interferon. And then there are a number of clinical trials that are either ongoing or soon to open. So there have been a few studies with TEAD inhibitors. So TEAD is one of the proteins that's important in the Hippo pathway that's involved with the fusions that we know are present in EHE. They haven't all been reported yet, so we're eagerly awaiting those results. And then there's another study with a different version of sirolimus that is currently being activated, so it's not open yet, but it's expected to open probably in early 2026, if I had to make a realistic estimate, which is, at least in theory, a more potent version of sirolimus. And that's also being run through the same cooperative group that ran the trametinib study through SARC. One thing that I think is important to note is that we will often want to use local treatments, whether it's surgery or various interventions, like with interventional radiology. We'll generally prioritize actually the local interventions, but systemic treatments are prioritized when either a surgery or some sort of intervention, like a histotripsy, is not possible. That might be if there are too many sites of disease and they can't all be treated with an ablation or with histotripsy or surgery. If there's an important structure that is in the way, and I imagine Dr. Wang and Dr. Shyn will talk a bit more about that and how they try and protect any important structure or organ, or if there are multiple organs involved, sometimes it's not safe to do an intervention on multiple things all at the same time. So to summarize, we'll use chemotherapy, but it's not terribly effective, certainly not as effective as we would like. Targeted agents are being used more frequently, especially sirolimus or rapamycin's, another name for sirolimus. There's potentially a role for immune therapy, but I think we need to better define what exactly that is. And there are a few studies that are ongoing or will soon be open that will hopefully lead to improvements on the systemic therapies. And sort of one last thought, and why I'm saying all of these things in a talk or session that's devoted to histotripsy, is that sometimes we'll combine all of these modalities and try and treat or ablate as many tumors as we can, but still also use a systemic therapy, either as an adjunct to whatever the surgery or interventional radiology technique is, or to try and facilitate. So sometimes we'll use a systemic therapy to eventually get to the point of, or having a goal of getting to either a surgery or an ablation. So thank you, and I will hand over to, I believe, Dr. Shyn. Or I don't know when you want to do questions, but.
Yes, I think Dr. Shyn is ready to come on.
Oh, perfect. Okay. Let me stop sharing.
Yeah. So then on the bottom here, you also have this. All right, thank you, Michael, and everyone. It's great to be with you. And then you also have a dial. Is my slides showing?
We see your slide. Thank you.
Okay, great. So I apologize. I'm actually in an operating room, but we do not have a patient in the operating room. But there is going to be a little bit of background noise, and I apologize for that. Dr. Wang is finishing up another case, and he'll hopefully join as I finish. But my main objective here is to kind of give an overview of histotripsy. So at Mass General Brigham, and specifically at Brigham and Women's Hospital, the histotripsy program was initiated by Dr. Wang, and he wanted me involved, so we do it together. So we've been running the program together, and so I'll talk a little bit about what histotripsy is, and of course one of the things that has generated a lot of excitement about histotripsy is that it is a non-invasive local therapy. And it literally involves no incisions, needles, no ionizing radiation. It's just ultrasound being transmitted through the skin into the body to treat a tumor. And you may have heard of focused ultrasound in the past. And so that was sort of similar, using ultrasound to treat tumors, but that older technology would just focus a constant beam of ultrasound at a point to cause heating of the tissues, and it was essentially a thermal ablation method, and it's still used for some things, but the histotripsy is quite different. If you want to compare it to something, it's a little bit more like lithotripsy, which you may have heard of as a way of using ultrasound to break up kidney stones, for example. But in the case of histotripsy, the device is optimized and tuned so that it will rupture soft tissue. And so the way it works is the treatment device focuses very short microsecond pulses of high amplitude ultrasound waves. And when those hit a point inside the body, they're focused at a point, it causes a rapid expansion and contraction of tiny gas bubbles or tiny pockets of gas in the tissues that expand and contract, and that mechanically ruptures cells. And it does so in a very small sub-centimeter focus. And so to treat a tumor, the device delivers very precise overlapping treatments with these pulses until an entire volume of tissue is destroyed. And it, as I'll show you, it essentially liquefies tissue, and the treated area, if you look at it under a microscope, there's really no recognizable tissue left at the end of the treatment. So histotripsy was recently FDA approved, but it is certainly in its early stages of development. So I would say we're using first generation histotripsy technology. We expect that the technology will improve, over the coming years, and also clinical experience with histotripsy is so far pretty limited. Worldwide, there's probably been about 2,000 cases in the liver performed, and we'll talk a little bit about published results also. So besides being non-invasive, the things that make histotripsy sort of intriguing are, one is that when you treat a volume, such as a spherical volume, it's a very sharply circumscribed area that is completely destroyed compared to what's completely unperturbed outside the treatment volume. So you have normal tissues that have not been injured, and then a sharp demarcation where all the tissues inside the treatment volume are essentially liquefied. And so it's a very sort of precise way of delivering very targeted therapy. And then the other thing is that the ultrasound pulses tend to spare connective tissues within the tubular structures like bile ducts, arteries, and veins, and therefore those structures tend to remain intact after histotripsy. In fact, you can even see blood vessels coursing through a treated volume of tissue without causing bleeding. So bleeding is quite uncommon with histotripsy as a complication. Bile duct injury is quite rare with histotripsy. So that's one of the attractive features. The other thing is that when we do thermal ablation to treat tumors, we're trying to either heat a tumor or freeze a tumor. And when you have large blood vessels next to the tumor, those blood vessels act like a radiator, taking away the heat or cold as we apply it. And so that means that sometimes tumor cells can survive on the right next to the blood vessel if we don't get it cold enough or hot enough. Histotripsy is not really impeded by that. It's not hindered by the heat sink effect. And then finally, there's some suggestion that at least some proteins remain intact after histotripsy. And the reason this is intriguing is that if it leaves tumor antigens intact, tumor proteins or antigens, that might help stimulate the immune system to attack other tumors in the body if they remain intact. And so that is certainly something that has gotten a lot of attention in discussions about histotripsy, but it is important to note that histotripsy alone seems to very seldom cause this effect where other tumors in the body shrink after treatment of another tumor with histotripsy. We think that maybe in the future, if we can do studies where we combine histotripsy with immunotherapies, maybe that will help increase the likelihood of these so-called abscopal effects where other tumors are sort of shrunk by the body's immune system. But just as a standalone treatment, that's not something we expect or see with any frequency. So this is just kind of a picture showing what the setup looks like. There's a table that our patient will lay on, and then we have a device on a cart that has a large computerized operational screen, and then a treatment head that comes over the patient. The treatment head is placed in a water bath that rests on the patient, and the water bath is sort of like the coupling mechanism where it allows us to get the ultrasounds from the treatment head into the body efficiently. And so, and then we use another machine, which is an ultrasound machine, to help us with planning and targeting. And you can see on the top right, far right, there's a view of the treatment head, and there's actually an ultrasound transducer built into the treatment head so that we can see with ultrasound the area that we're treating as we treat it. So I'm going to try to play this video. Let's see. Oh, it's not going to play. Okay, so what this was, basically this was a phantom. So this was a gel phantom that was treated with histotripsy, and it was a solid block of gel. And after the histotripsy treatment, this cavity that you see here was completely liquefied. And when they sliced it open, the liquid just poured out. And that's kind of what happens when we do histotripsy. It just liquefies or partially liquefies the treated tissues. Let's see. Trying to advance my slide. And it doesn't want to advance. Let me see. Okay. So when we do the treatment, this is kind of what we see during the treatment. So it's ultrasound guided, as I mentioned. We do these procedures under general anesthesia, so the patient is completely asleep with a breathing tube. And the reason for that is that we want to minimize breathing motion of the liver, and that helps us target the area more accurately. And you can see on the left screen, the red and orange lines kind of show the area that we're targeting. The crosshairs show where the beam is starting to apply histotripsy pulses. On the middle screen, we're monitoring as we apply the pulses. And then the right-hand screen shows an area that's been completely treated. And then afterwards, so on this screen on the far left, you see what a tumor looked like. It was kind of about a 2.5 centimeter round, dark tumor there in the liver. And then after treatment, you can see we always want to treat an area larger than the tumor so that we get all of the tumor with a so-called margin. In other words, we want to treat beyond the tumor so that we reduce the risk of it coming back. And then a month later, the scan shows that the treatment volume has shrunk dramatically to even smaller than the original tumor size. And that's because we, again, liquefied the tissue in the body. It kind of gets resorbed pretty quickly. And so at a month, the treatment zone is quite small. So the clinical trial that led to the FDA approval was the Hope for Liver trial. And in that trial where they were applying histotripsy to patients with liver tumors, they enrolled 44 patients. About 18 of the patients had hepatocellular carcinoma or primary liver cancer, and then the rest had metastases that went to the liver. And their primary endpoint was technical success, meaning that they completely destroyed the tumor with no visible residual, and they achieved that in about 95% of tumors. And then from a safety point of view, the major complication rate was about 7%, which is not atypical for our local therapies in the liver. And if you look at those major complications, there were 3 of them in the 44 patients. One of them was a patient who already had extensive tumors replacing much of the liver, and that patient died more than a month later from liver failure. We honestly don't know whether the histotripsy caused the liver failure or whether the patient would have gone into liver failure anyway, but that was considered one of the complications of histotripsy. And then another patient had infection, a blood infection, and it turned out that patient had a biliary stent, which is a tube connecting the bile ducts in the liver to the bowel. And that means that bacteria have colonized the bile ducts in the liver. And that's a well-known risk factor for liver infection and complicating a local therapy. So it's something that we generally avoid doing. The patient did recover with antibiotics, and then another patient had pain that resolved with pain medication. So overall, the study met the efficacy and safety endpoints, and so it led to FDA approval. And like I mentioned before, there's probably been about 2,000 or so cases done around the world to date. But in terms of what's published, we have relatively little data published, except for the Hope for Liver trial, and I'll show you another paper that was published. As far as I know, there have been no case reports or case series reporting histotripsy for epithelioid hemangioendothelioma. I can't say that it hasn't been used, but there may be some centers that have treated a few of these tumors, but it hasn't been published yet that I know of. But I certainly think that histotripsy could be considered an alternative local therapy for EHE tumors in the liver. It's probably not likely to be used in the lung because the ultrasound doesn't penetrate aerated lung very well. And so that's going to be a limitation in the lung. In general, while there's a lot of excitement about histotripsy, there are limitations. One is that we have to be able to see the tumor with ultrasound, and so that excludes some tumors. The tumor can't be too shallow or too deep. If it's too close to the skin, we have to be very careful not to cause a burn of the skin. If it's too deep, we just can't reach it and deliver enough energy to treat the tumor. And then certain types of tumors are likely more resistant to histotripsy, like fibrotic tumors. And then motion is an issue. That's why we use general anesthesia right now. It would be nice if for a non-invasive treatment like this, we didn't have to use general anesthesia, but for the liver, we do. And then there can be metabolic effects when you treat a large volume of tissue that can cause metabolic effects that impact kidney function. And it can cause clots in adjacent blood vessels. That's usually not clinically significant, usually resolves on its own. And then we have to be careful not to injure bowel loops if they're right next to the treatment zone. So I mentioned that there are some publications. This one on top was came out recently, and it's kind of the experience in New York at one of the centers there that has been doing histotripsy, and it kind of has similar results as the Hope for Liver trial, which is the second reference listed here. This Hope for Liver reference includes a 1-year update of clinical outcomes, and that was published this year. And then the third paper is also a study of, I'm sorry, the first paper was actually Dr. Wagner's paper, which is just an overview of epithelioid hemangioendothelioma and the medical treatment and alternative treatments, including local treatments. And then the third reference is the one from New York that reviews their experience with histotripsy. And then the fourth one is just a paper we published that looks at the our thermal ablation experience and IRE experience with epithelioid hemangioendothelioma. So in conclusion, I would say that the histotripsy technology is very exciting. It is in its early stages, and we do expect improvements to be coming over the coming years. Insurance coverage has been a challenge, but we do our best to work with the insurance companies on that. The exact role of histotripsy in the spectrum of local therapies is really yet to be determined. And so if you're considering a local therapy, then certainly you want to talk with your oncologist and your interventional radiologist, your surgeon, radiation oncologist, just kind of get as much information as you can before you make a decision. And then just as an aside, future applications of histotripsy will likely include kidney tumors, tumors of the prostate, breast, thyroid, and soft tissues. So with that, I will stop. I think Dr. Wang is still in the OR. So he was going to just mention the surgical options. Jiping, can you talk?
Yeah.
Okay, so actually perfect timing. Dr. Wang just got out of the OR, so I'm going to hand this to him. This is your slide. You're talking to here, and then you can control the slides with. This is the only slide.
Yeah.
Okay.
Hey, everyone. Sorry I was late. I was in the other room to do liver surgery. So for EHE, there is limited role for surgery. Did you talk about the ablation as a histotripsy part? Yeah. So obviously, when patient is a candidate for transplantation, we will recommend patient transplantation is a particular priority. However, for patient has, for whatever reason, patient decline transplantation, for patient has no actual hepatic disease, surgery might play a role, especially in combination with other treatment modalities such as different technique of ablation therapy. We just saw a patient at clinic yesterday. So there is a possibility of creative combination of ablation of the left lobe of the tumor. This allow us to resect the right lobe, and then we can spare the middle section of the liver. In that situation, liver the surgery play a role to hopefully improve patient quality of life and also to have reasonable disease control. All right, guys, we have arrived.
So I guess what we'll do is we'll stop there. Let me stop sharing my screen and turn it back over to our host. And if y'all want to do Q&A, we're certainly happy to try to help with that.
Yeah, thank you, Dr. Shyn, and thank you, Dr. Wang. We're very grateful for you giving the time and stepping out of the OR. This is great. And Dr. Wagner's still there too, I think. Dr. Wagner, are you still with us?
Yep,
Yeah.
I'm still here.
If you want to jump on screen too, that's fine. We'll go through. We have some questions that have been submitted in advance of today that I want to ask of you all, and then there are a few that we've gotten during this session today as well. One of the earlier questions that we received was about histotripsy working for larger. And I'll combine that with, someone who has a higher tumor burden in their liver. Can you speak to that again?
So for patient has multiple tumor in one segment or one lobe of the liver, then surgery make a lot of sense to remove that segment of the liver. However, for patient has multiple disease in both sides of the liver, then if it's feasible, we can design the treatment modality with combination of local therapies, ablation technique, either use cryo, RFA, or histotripsy to ablate one side of the liver, and then we can do other treatment modalities, such as we use a portal vein embolization to boost for example, use the left lobe as an example. We can boost the left lobe. This allow us to resect through surgery to remove the right lobe of the liver.
Okay. Just mentioning, Dr. Wang, you were talking about consideration for transplantation over something like histotripsy. Can you speak to some of the considerations, some of the factors that might make you make that assessment or make that recommendation for a patient? I assume that we might get that question after this session.
Yeah, so for liver has, first of all, for patient we don't have any options. For example, any type of local therapy or surgery is not feasible. And then we do have other treatment modalities such as TACE or 190, but you can only get certain disease control. Eventually, the tumor will progress. In that situation, that we will recommend patient get evaluated for liver transplantation team to see whether they are a transplant candidate. Nowadays, a lot of places even offer live donor liver transplantation. So we have quite, it's not restricted by, to a certain degree, not restricted by the liver availability anymore. Yeah. For young patients, I strongly recommend a patient get evaluated for transplantation because those patients will have very significant quality of life improvement with the liver transplantation and, can cure the disease.
Dr. Wagner?
Can I chime in there? So I think for some patients, I would agree with that statement, but I think honestly for most patients, I am very reluctant to recommend a liver transplant. There were consensus guidelines that were put out, I forget exactly when, but they do comment on liver transplant. One of the things that are actually mentioned is that for patients with disease outside of the liver, they don't recommend a transplant. So I just want to make sure that that's mentioned. And then there is still a lot unknown about what are the long-term outcomes of a transplant. And there is a lot of at least potential risk with a liver transplant where I don't actually know what the percentage of all people who have a liver transplant is who have bad outcomes, even up to including death just from complications of the transplant itself, but it's not insignificant. So I think for patients who have, like what you said, multifocal disease in the liver, where surgery and or ablation or some combination with histotripsy aren't possible, then I do think transplant certainly makes sense. But I generally would consider transplant as not the initial sort of intervention. I would generally actually pretty strongly favor what Dr. Wang and Dr. Shyn might actually be doing right now, which is some combination of an ablative technique, whether it's histotripsy or cryoablation or any of the other things Dr. Shyn can offer with surgery. And then only if that's not possible or if there's growth beyond after that's already been tried, that's when I would kind of more strongly consider a transplant. And I think there's a lot of just personal preference too, which kind of and biases, which makes these decisions much more difficult, and it's always a conversation. Where for someone who does choose to consider a transplant, then those risks have to be laid out very clear, because it's very easy to say just get a transplant, but then it's actually a very big surgery. Dr. Wang is used to doing very big surgeries, so that's
you touched on something, and all of you may be able to chime in on this. So we did have a question from someone who has a newer diagnosis, and as you know, many people are diagnosed with EHE and they aren't symptomatic. They may or may not have metastatic disease, but they still don't have a lot of symptoms associated with their disease. If someone came to you and they're newly diagnosed and they are considering a significant intervention, for surgery, and they're newly diagnosed, what Dr. Wagner, what's your, initial approach on that as the medical oncologist? And then from a surgical and radiological approach, what do you say to those patients?
Yeah, so I have to say, I think your audio cut out at least briefly when you were talking. But if I understood the question, I think you're asking, so how do we think about approaching someone who's newly diagnosed?
Yes.
And I guess I'll focus on liver disease at the moment, because if it is more widespread, then I would generally consider, I mean, unless there's obvious growth or symptoms, where I would try and prioritize something systemic. Um, it's a discussion where generally we would watch and get a relatively short interval scan in, say, 2 months or 3 months, just to actually see, is this something that's stable and potentially has been there for a long time, where a lot of EHEs are just diagnosed incidentally. So someone goes in with appendicitis and gets a scan, and this lesion is seen on the liver that is then worked up and then found to be EHE. So sometimes we can just watch people like that. If it is localized and it's known to be an EHE, then regardless of whether or not it's indolent, then I would still say, see someone like Dr. Shyn and Dr. Wang to get it out, because we don't want to give it a chance to potentially become more aggressive. But for someone who's first diagnosed, I think key things are they symptomatic? Is the disease growing? Then something needs to be done, sooner rather than later. But if they're not, then it's something that can be watched just to get a sense of what's the pace of change of that particular tumor. If it's localized then and known to be EHE, I think regardless, being evaluated by surgery and or interventional radiology should happen, because we don't want to give anything a chance to become more aggressive. And it's always a conversation, because everyone's different, even with the same disease and same diagnosis. There's not one right answer for any one particular patient.
Yeah, yeah. I unfortunately, I think we lost, oh, Dr. Shyn's phone battery died. I was worried about that happening, and I think he was connected on his computer just for the presentation only. So Dr. Wagner, you're the Q&A guy now. You might know this, are patients under the age of 18, are they able to be looked at for histotripsy? Are they even evaluated or not? Do you know?
I don't know.
Okay.
That is a good question. We can ask Dr. Shyn after, or maybe if he's on chat.
Okay.
We can ask him, but I only see adult patients, so I'm just less familiar with what's
Okay.
potentially even available to kids.
Gotcha. Are there, and forgive me if he didn't say, okay, Dr. Wang is trying to log back in, so we'll see if we get him. I don't remember Dr. Shyn saying this specifically, but would metastatic disease outside of the liver rule out histotripsy? Would that be a reason that?
So that I can answer. The answer is no.
Okay.
And in part, it's because this is something that can be so indolent for so long. So just as an example, if someone has a number of lung nodules, but primarily liver disease, and especially if we've proven that those lung nodules have been stable over a period of time, then we would still very much consider treating whatever disease looks the most potentially problematic. And that could even be something like surgery, or a combination of surgery and histotripsy, or surgery and some of the other ablative techniques. So we would definitely consider it. It's just a question of where is the other disease and what exactly is the biggest problem area.
Okay. So there were two questions about kind of looking to, what could happen after you have histotripsy. One question was submitted earlier about whether or not you might anticipate the abscopal effect with histotripsy, and Dr. Shyn touched on that. Do you want to make any further comments on that?
Yeah, I mean, I think we don't really know. Of course, there's some hope that we would see something like that. I wouldn't say it's an expectation, but is it possible? I suppose it's possible.
A good outcome?
You mean with abscopal
Yeah.
effect? Yeah, so I mean, well, what is the abscopal effect? Let me sort of, I guess, answer that question first. So it's when you treat one tumor, but then sort of trigger an immune response in disease that's elsewhere. So that's something that has definitely been documented in other cancers. Just as an example, so if someone has radiation to one tumor, then it's not very common, but we'll sometimes see shrinkage in other tumors elsewhere in the body. And that's at least possible, I suppose, where if we're liquefying a tumor in the liver and that triggers some sort of immune response, then in theory, an abscopal effect or an immune response that would be more systemic, just because our immune cells and our white blood cells circulate all over the place. It's something that would be great if it happens, but certainly for EHE, I think it's unknown whether or not that's something that we would see.
Yeah, too little data. And the flip side of that is there a risk of rocking the boat with EHE in tumors of other locations where you cause something else to occur or the disease to become more aggressive?
So actually, Dr. Shyn, it looks like, just answered that in the text. So he said that it's not likely, I'll just read what he wrote. So histotripsy is not likely to cause other tumors to explode or grow faster. There is one case report suggesting this happened in someone with cholangiocarcinoma.
I'm here.
But I wouldn't, oh, excellent, Dr. Wang's back. But I don't think that's an expectation, where, I think that would just be a risk, but I don't think that risk would really drive the decision-making of whether or not to pursue histotripsy. And then to answer the question about are children potentially eligible, so what Dr. Shyn said, oh, actually, he's on too, but he said that we generally don't see pediatric patients, or he doesn't at the Brigham, but it's not necessarily impossible. So I guess it could be discussed.
So, sorry, I missed the previous trying visit to log in. So I did want to make it clear that there's no solid data say, hey, histotripsy is, definitive treatment for EHE. All these are, with FDA, approved indication for liver metastasis, but there's no head-to-head comparison data for the histotripsy versus the other treatment modalities such as microwave ablation or cryo. I don't want the audience to take away the wrong message and say, hey, we're going to prioritize histotripsy versus the other traditional treatment.
Understood. Yes, and there's little data really on long-term outcomes on any of these interventions for EHE. So that is an important takeaway. Thank you for clarifying that, and thanks for making a good effort to get back on with us. I wanted to, let's see, there was another question that came in that I was just looking for. Someone just asked. They said that it wasn't clear how large or small the liver tumors can be to qualify for histotripsy.
So in general, we probably are more effective with tumors that are not bigger than 3-4 centimeters. And part of that is the way the device works. It can treat up to about a 4 centimeter diameter volume in one application, but to treat larger tumors, you have to do overlapping treatments, so it gets challenging. The other limitation is if it's very large, then you're histotripsying a large volume of tissue, and that can have metabolic effects that I alluded to in my talk. So if you have many lesions, like, more than 3 or 5, we would not try to treat all of them in one session. We might treat a couple of them or 2 or 3 of them in one session, depending on how big they are, and then consider additional treatments later on. So size and number is a factor for it's a factor for histotripsy. It's also a factor for ablation.
Yeah, again, if we encounter that kind of situation, it is the design of treatment come in play a role, right? I mean, you can have combination of for bigger tumor, peripheral, you can treat it with surgery, and then for smaller, the deep inside or near the bile duct, you can treat it with histotripsy, combination together.
Okay. I think we're getting close to the end of the hour. I want to ask one final question if I can, and I'm not sure which of you might want to take this. So, and this is kind of a combo question. What steps does somebody need to go through if they want to get considered for histotripsy? And think about that from the standpoint of, maybe there are people that are not being seen at a hospital that's doing histotripsy. But even if they are, do they talk to their medical oncologist? Do they try to get an appointment with a surgeon or radiologist? What does that look like? What would you recommend people do?
Usually, if you the Histosonic had their website that has providers across the United States. You can search whichever center who has a machine close to you, and then usually they provide a line for consultation. If not, I would say just go to your medical oncologist, and they usually connect with one of the provider near you.
Okay, excellent. And Dr. Wagner, as a medical oncologist there, I'm assuming that you would see your EHE patients and talk with them about, you've mentioned multiple options for intervention today. So you would talk with them about this as a possibility as well as any other intervention, and then make those referrals. At your institution, does a person require a referral from you to get to an evaluation for an intervention like this?
No, usually we will, once we see the patient which is suitable for multiple treatment modality or need a combination of multiple treatment modality, we will send the patient to the tumor board where we meet together every Wednesday afternoon. The medical oncologist, radiation oncologist, interventional radiologist, or surgery together. And also the histotripsy provider, me and Dr. Shyn, one of us will be there too.
Excellent. Very good to know. Which builds our case for making sure that patients with EHE are seen at centers with multidisciplinary care, particularly those that are experienced in sarcoma. So this is great. I don't think that there are any other questions that haven't been addressed through your presentation. We really, really appreciate you all taking the time. Dr. Wang and Dr. Shyn, really thank you a lot for joining us from the OR. We appreciate it, and thank you for getting through your technical difficulties there. Dr. Wagner, thanks for writing your paper recently, which prompted us to reach out to you all and make sure that we can bring this to the community. So thank you. We appreciate your time today. As Maggie said, the session was recorded. It'll be published in a couple of weeks, 1 to 2 weeks, so you can rewatch it. If you have additional questions, feel free to email us at info@FightEHE, and we'll answer those or get those answers to you as best we can. We can't give medical advice, so we'll see if we can get good answers for you. And stay tuned. In the next week or so, you'll see another educational session published on genomic sequencing, which, as Dr. Wagner touched on, that is an important aspect for EHE patients and the medical community to know as we look forward to developing new treatments for EHE. So thank you all. We really appreciate your time. Thanks for being with us today.
Thank you.
Be well. All right. Thanks, everybody.